Today's webinar is titled A Conspiracy: How Hidden Curriculum and Bias May Be Affecting Our EMS Learners, presented by Dr. Jamie Kennel and Douglas Randell. I'm going to pass it over now to our presenters. Thank you both so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Excellent. Thank you, Rio. Randall, I think we should introduce ourselves first. Do you want to go first while I'm pulling up slides?
Yeah, that sounds like a great idea. Hello, all. My name is Doug Randell, and I am the lead educator for a company that I'm a part of called Communicate and Document. And we're looking at ways to make EMS better through education and consultation.
Awesome. And Randall, can we see, is it the main slide or have I?
You got to flip it. It's the.
I always get this mixed up. Thank you.
So it's all right. There you
How
go.
about that? All right. Thank you. So my name is Jamie Kennel. I'm a professor at a university, Oregon Health and Science University and Oregon Institute of Technology, where we have a EMS department. And I've got a team of folks that teach and do research on a bunch of different topics. So thank you for coming. And this can be a difficult topic to discuss. So we're really happy that you've come out this morning, at least morning West Coast time. Hopefully lunch on East Coast time for you to have some of these conversations. Next, I want to say I'm a cisgender hetero white dude. That means I've got a certain lens what I see and experience the world through. That lens is biased. I've been working for years through doctorate programs and research to try to make sure that that lens is as clear as possible, but it still has bias. And so this portion of the talk is seen through that lens and is not perfect. So I just want to have that disclaimer out there first. All right, so we've got a bit of a logical structure here, and please, as you have questions, as Rio suggested, drop them in the chat. Douglas will be monitoring those for me during my portion, and we'll interrupt and ask questions as we go. So please do that, or if you want to save questions to the end, that's also just fine. We can do that. So first, we thought we'd cover a little bit about what's the evidence we have a problem that we need to take action on. I think this is a great first step to see what does the problem look like. Then we're going to cover a little bit about why is this happening? What's the evidence to suggest? What are the mechanisms behind this is taking place so that we can inform our interventions based on the mechanisms? So first, when we look at a problem, we're going to look at three areas of evidence: patient care evidence, EMS student evidence, and some workforce evidence. So the treatment disparities research started with this seminal study by Schulman back in the 90s. They asked 720 primary care physicians to recommend a treatment plan for these 8 patients. And these are specifically the 8 patients. They all had identical complaints of chest pain. Physicians were given a recorded interview as well as written background lifestyle information and medical information for each of these patients. Every detail about this interview and background were identical in this experiment. And this is a prospective experiment. The only element that varied in these video vignettes was the patient's race and gender. Otherwise, all the details were the same. And they found a few interesting items, as you might imagine. First, when compared to white men with identical conditions and presentations, they found that Black patients and female patients were 40% less likely to be referred for cardiac catheterization, which is the most appropriate treatment given the patient's condition. And importantly, they found the intersection of if you were Black and female, you were 60% less likely to be referred for this appropriate procedure. Remember, identical complaints, identical medical background. The only thing that changed here was the gender and the race. This is really the study that kicked off what are now hundreds of studies that have demonstrated racial disparities across almost all areas of medicine that have been studied, hospital-based medicine. And just to recap, one of the first EMS-based studies that looked at racial disparities in treatment was done by Dr. Young, looking at in Contra Costa, excuse me, this is hard to say, Contra Costa County there, down in the San Francisco Bay Area, and found that Black patients were 45% less likely to receive pain medications when they looked at blunt trauma cases. And this was back in 2013. Next study came out using national data from NEMSIS and looked largely at descriptive studies or descriptive data in 2017, finding all racial minorities were less likely to receive pain medications when they looked at fractures, burns, and penetrating trauma. So we're starting to see some consistency in the EMS treatment disparities as we have in hospital-based settings. My team and I looked at this, particularly in Oregon. We did a bit of a deep dive on Oregon NIMSIS data, and we found some similar results. We found Hispanic populations and Asian populations were less likely to receive a pain screening for traumatic injuries by EMS providers in Oregon. Sorry, for pain screening. And remember, this is just the simple 0 through 10 being captured on the chart. And then we found all racial minority categories were less likely to receive pain medications in Oregon by EMS providers for traumatic injuries. This was published a little while ago in the journal Medical Care. And then more recently, some excellent evidence here. Sorry, I got 2 more papers to review. So Dr. Crow and I, as well as a team listed here on the bottom, published a study recently in Annals of Emergency Medicine, where we looked at patients who had a confirmed long bone fracture as diagnosed in the hospital, and then we looked backwards into their EMS chart, and we wondered who received pain meds and who received a pain screening for this objectively, excuse me, objectively painful injury. And you can see the results here. Largely Black patients, 35% less likely to receive pain meds. And we also looked at socioeconomic status. And I can talk more in detail about how we did that, but one of the critiques was that what we're seeing is not really about race, but it's about socioeconomic status. And so we captured that using CDC data, and then we teased out the difference between the racial impact and the socioeconomic status impact. And so what we're seeing here is the Black patients were still 35% less likely to receive pain meds, independent of socioeconomic status differences. Further, we found that in general, if you were poor, you were less likely to receive pain medications as opposed to being rich for the same long bone fracture, which should be equally concerning to us. One additional kind of myth-busting element that we did in this study is we reviewed about, if I remember right, close to 500 narratives in the EMS chart to look for differences in refusals of pain medication primarily. One of the critiques in some of the past work has been racial minorities are more likely to refuse pain medications, and that's just not captured well in the chart. The charting practice, that is true. We don't have a good way to do that yet. So we looked at patients that had confirmed long bone fracture in severe pain that did not receive pain medication, and we found no differences in the rate of pain medication refusals captured in the narrative. In fact, we found the opposite. We found preliminary data that suggests white patients were more likely to refuse pain medications than African Americans. Moving right along, there was an excellent systematic review by Dr. Farkas that looked at all of the disparities research in EMS. And you can see here they reviewed 145 peer-reviewed articles. Importantly, they found disparities were identified at all phases of EMS care, right? And we can think of all phases as being access, response time to the call, treatment when a team is on scene during a call, transport times and appropriateness for the hospital facility where patients get transported to, and then outcomes as well. So really powerful study to summarize the work here. Finally, if we look at students, what about students? Well, Dr. Lord and Sahej did excellent work a little while back in 2019 looking at our students coming out of schools with racial bias that lead to racial disparities. So they looked at 60,000 patients treated for traumatic injuries when a student is on externship. And what happens? They found evidence that Black patients were 40% less likely to receive pain medications, as well as the disparity for Hispanic patients. So very similar to what is found in the field. And then finally, one additional area to look at disparities is in workforce makeup. So maybe let's take a second here. Anybody guess what the percentage of physicians who are Black men in 1940 were? Give you a second to think about what your guess might be. Drop it in the chat if you feel so inclined. The number is really 2.7 of physicians who were Black men in 1940. So one way to look at workforce diversity is to see if all of the efforts that we've taken have improved this. So this particular study looked at what are the percent of physicians who are Black men more recently in 2018. Unfortunately, it's largely the same, arguably is going down, right? Huge amount of time frame, huge amount of effort. Still, there's a very small proportion of Black men who are physicians. What if we looked at this in EMS? Our colleague Dr. Crow did a study with a team here, published in 2020. We looked at EMS clinicians who were Black in 2018. And here's what they found. 5% of EMTs were Black and 2% of paramedics were Black in 2008. Has it improved in the 10 years since the study in 2017? Largely, the answer is no. Still, 5% of EMTs are Black, and you could argue this is a rounding error, it's so small, but we went from 2% to 3% of paramedics are Black in 2017. So we think there's lots of evidence that we've got some challenges here. So the next part of making sure we can design solutions that are effective is we need to better understand why this is happening. So we want to look at a handful of items here. These are some of the items that the literature suggests are reasons that this might be happening at the provider level, if you will. Racism being a structural topic. There are more reasons that this takes place, but as we talk to individual providers, these are some of the mechanisms that have function at the provider level. And we'll just quickly run through these. So first is an understanding, or I should say, importantly, a misunderstanding that race is biology versus race being a social construct. Importantly, there are no medically significant biological difference between individuals of different races. Unfortunately, many folks in the medical field still believe that this is true. One great study by Hoffman, while she was a doctorate student at University of Virginia, published a fascinating study here that looked at understanding of medical students' incorrect beliefs about race as biology. And she found some fascinating items. First, she surveyed medical students who were in their first year and who were in their second year. And these are two different cohorts, just importantly. She just studied both cohorts. This isn't the first year cohort and then surveying that cohort in year two. This is two different cohorts. So some commonly incorrect understandings about race as biology that are proven false, she asked medical students about. And this is the percentage of medical students that said, yes, this is true, right? So the first one, Black people age more slowly than white people. An uncomfortably large percent of medical students agreed with this statement that, yes, that's true. Let me reemphasize, these are all false understandings. These have been proven false. Black people's blood coagulates more quickly than white people's. Very large percentage, 29% of first-year medical students believe that that statement is true. Black people's skin is thicker than white people's. Very common. I see this in EMS in our department for students that start with this belief that Black skin is thicker. And it's also true with medical students, right? 42% said, yes, that's true. Black people have a more sensitive sense of smell than white people. And finally, getting at pain medication, Black people's nerve endings are less sensitive than white people's, right? Some crazy beliefs that may be underpinning providers' delivery of substandard clinical treatment may be a misunderstanding about race as biology versus a social construct. Douglas, how are we doing on questions?
No questions at this point, but participation is great.
Excellent, thank you.
Mhm.
So second reason why this might be happening is representation. My team looked at two different medical EMS textbooks here. You can see the AAOS textbook and the Brady's textbook. And we were wondering how often are racial minorities depicted in these textbooks. So we did a study where we looked at every single image in both of these textbooks. And we cataloged the perceived race and gender of the people in the image, as well as their role. Were they the patient? Were they the provider? Were they the bystander? Were they police, etc.? And we found a handful of interesting information. First, the question is who is depicted? So we found Hispanic patients made up 19% of the US population at this time, yet only represented 2% of the images. Right? Asian individuals made up 6% of the population and only represented 2% of the images as well. And women made up 50% of the population, but just represented 12% of the images. So we're beginning to see there's some disparity on who is represented. The next question we asked is when they are depicted in textbooks, how are they depicted? So what role did they play? This is where it gets even more interesting, right? So Black individuals, 31% more likely to be depicted as a patient versus a clinician. So when you think about careers, it's really powerful to be able to see yourself as a provider in order to have that career be on your list as a student. So here's many more cases here, right, of not being able to see yourself. Asian individuals, 192% more likely to be depicted as a patient. Women, much more likely to be depicted as a patient as well versus a clinician. So this sends a message, this is a challenging message in two ways. One, if you're a racial minority or a woman, excuse me, you are less likely to see yourself as a clinical provider. Also, to all of the white providers who are being trained as an EMS provider, you are now seeing stereotypes depicted as racial minorities and women are much more likely to be patients and not your colleagues, right? Which is reinforcing a divide here. Next reason why this is happening is stereotypes and cognitive load. So in EMS, we've got to make often some rapid decisions with imperfect information. So we know those situations can create a high cognitive load, which causes us to lean and use stereotypes. We have to use stereotypes, super important. However, those stereotypes often come with baggage, and that baggage can lead to treatment disparities. So when we have situations where we need to make quick decisions with imperfect information, we need to recognize that we're going to use stereotypes, and there's some good and bad parts to that we need to take into place or take into account, and we'll talk a little bit more about that later. And then finally, one of the final areas that is one of the mechanisms behind racial disparities, we believe, is language barriers. As many of you is probably were thinking about this. Patients who are unable to speak English or are not proficient in speaking English, rather, are coined LEP, patients with LEP, limited English proficiency. There's a lot of them, 25 million or 8.5% of the total populations. They're much more likely to be racial minorities, and they're twice as likely to live in poverty compared to patients that speak English. They receive a lower quality of medical treatment in the hospital, including the emergency department. And so it should be no surprise that they likely also receive substandard treatment within EMS. So did some work locally here on the West Coast to get our arms around this, because this is also poorly charted. And this is data that's being submitted for publication that you get a glimpse at here. So looking at a city on the West Coast through narratives, because the charting environment isn't great yet about capturing language barrier patients comprehensively. So we found 1,155 cases of patients who were unable to speak English, and we were interested in how many of them have an interpreter that's made available to them. Let me say, at this agency, there is a cell phone in every ambulance, and there is a language line on speed dial that's available in every ambulance. And that is the accepted practice. But roughly 50% of patients who were unable to speak English were not given any language interpreter, right? So most of these charts just read unable to communicate with a patient, and we loaded them and took them to a hospital where an interpreter was available. So you could imagine the reduction in the quality of care that was provided to those patients. When an interpreter was used, here's a breakdown of how that went. So family and friends were used most often, bystanders were used next, and you can see the official interpreter resource was only used 5.5% of the time. Right? There's lots of good literature, and it's best practice, as seen in the emergency department. If you're going to need an interpreter, we need to use an official medical interpreter, and it's inappropriate to use children or family and friends or bystanders. There are exceptions, but that should be the exception and not the rule. I'm going to cruise through these, just some statistical work to say LEP patients actually do receive less care, 63% less likely to receive a pain screening, and also 23% less likely to receive pain medications, as you might anticipate. All right, I think I've talked enough. Thank you.
All right. So let's talk about the groups that we are around. And we can talk about friends and family, but the reality is you are part of your environment in most cases. So as a result, you know that you have a group of friends and you have these similarities. And by default, some of those similarities could be because of your background, which includes your race. You stick together. As you see in this slide, you see the show called Friends, and on the right is a show that's called Living Single. And both of these are two groups of people that are just friends. And you can see where those similarities come from. Our goal here is not in the sense to disrupt what those social groups are, but to expand them. All right. So what happens when you have these same friend groups or homogeneous circles in leadership? Well, you get a lot of thinking that can be very similar. And so if you see this group of men running your fire or EMS agency, then what are they making decisions on when it comes to patients that are not like them, with students that may do ride-alongs that are not like them, with some of the employees that they may potentially hire that are not like them. So if this is the leadership, then the thought process has to be more intentional, because we do revert back naturally to what we know. And that's the groups that we're familiar with. So I took this class, right? And this class is about understanding who you are as a person, which includes understanding your friend groups and your world. And it was an exercise with the use of some marbles. And it was a visual exercise. So let's just go through this exercise together. So as I'm looking at the circles, these instructors say, okay, let's start with the first group. And the first group is your work circle, right? And so you go to work, you got these people, and if you're, most of these folks are a certain color, right? So I'm the black guy, right? And I got all this green And these are my white coworkers. It could be your white coworkers, right? And then your family circle. What's your family circle like? If you're a white person, they're all greens. If you're Black, it's a completely different color. It's blue. But what is your friend circle? So as you can see, all these circles could be very similar with an exception here and there. And so what does this mean? If you're a white person and your circle looks mostly green, which is depicted in a white individual, then does that mean that you don't understand anything about Black people? No, this just means as an awareness level, this is your group. So does it mean that you could probably expand the circle? And I'm going to say for all of us on this webinar, we all could expand our circles, which includes me. So this just gives you an idea. This is not an indictment. This is not to say the kind of person you are, but just think about your circle and think about ways to expand it. So how many of you have watched television and there are things that are portrayed and you're like, is this for real? Is this serious? Well, some of it is exaggerated through the media. And I know that was a spoiler alert for some of you, but it's actually the case, right? So 59% of poor families depicted as Black, we're only 27, and percent of those Black families are living in poverty. So when it comes to poor people, you're going to see that more with Black families than others. 60% of media portrayals of families relying on welfare were Black, even though only 42% of families on welfare are Black. So there are more white families on welfare, there are Black families by the numbers. If we only make up 11, if Black people make up 11, 12% of the population, then conversely, when it comes to those on welfare, it kind of matches up, right? It'll match up with more white families on welfare. And not to say that welfare is bad, but welfare was devised to help you get a step up on the world during tough times. So even the premise of welfare has been distorted in our society. The depiction of Black fathers as absent is strongly evident, but there's no proof, right, in cases. I grew up in a home with a dad and a mom, and so that's dispelled right there in that respect. And then we overrepresent Black families and the criminality of it, right, and underrepresent white families. And so there are a lot of TV shows and shows like The Wire and these other shows that are showing the grittiness of living in the hood, so to speak. Highly entertaining, but it exploits some misnomers in those areas. So just watching it for entertainment is one thing, and believing it is another. What about the school? So we have some educators on this webinar, and as educators in the classroom, our goal is to create the environment that talks about real life, not to give our students this, oh, it's not that bad out there, it's going to be wonderful, you're going to save lives. So we try to keep things as realistic as possible. And we let the students know that, yeah, there are some biases that are out there. There will be some patients that you're going to take care of that's not going to like you because of your skin color, because of your gender, because of how you identify, because of a religious belief that they may share. So there are lots of biases out there, and racial bias is one of them, and to be prepared for it. But I'm going to teach you all the tools you need to succeed. And so that happens in the classroom. The student feels empowered, and now it's time for them to go into an internship with this preceptor that was told they were precepting. And when they walk on an ambulance, the preceptor tells them, all right, let me tell you, my name's George, and I've been doing this for 30 years, and whatever they told you in that classroom is BS, and I'm going to teach you what's out here in the real world. And it essentially disrupts all the things you were taught because this preceptor has the authority to could potentially change the trajectory of this intern's life and career path. So they lean into what that preceptor is saying just to pass the program. So it's a very big problem when we run into these types of preceptors in this business. So we know we had a problem, and the good doctor already talked a lot about that. And we broke down some of the whys about why this is happening. And so our next step here is figuring out what can we really do about this. And so the first thing that we can do specifically is say there is a problem. Once we acknowledge the problem, now we can start attacking the problem. And we have to see the problem for what it is. As uncomfortable it may be to admit to it, it is a problem. So now, if there's a problem, now we're going to work on a solution. But the question that's overwhelming is, where do we start to find a solution to these problems? And so this is how we can do that. Okay. We get educated. We educate ourselves. We understand what some of these things mean, whether it's a privilege, whether it's the way folks are treated medically, whether it's different groups, women, for example, and how they have suffered over the decades, right? Like understanding what's happening. And that starts with the individual. And really, as the old saying goes, pick up a book.
Yeah, and that book list continues. Robert Will Johnson Foundation's got an excellent, I believe it's annual, although it might be quarterly book recommendation on these topics. So you don't have to go search for them. It's a curated list, which is excellent to look through. All fantastic books. So as we talk about patients with LEP, there's a number of things that we can do within our agencies or our school systems, right? So we need to better support these folks. Providers are going to do the best they can without a structure, and it's not going to be what you want it to be systematically. So we need to think about a handful of things at our agencies. We need to have a policy, a practice, and a guideline, right? We need to evaluate our field interpretation service. Is the tool terrible? And is that why people are not using it? Is it really hard to get a hold of people? Is it hard to find the right language that's being spoken? Really important legally that all of our systems use an official medical interpreter service. It's not, as I mentioned earlier, not appropriate to use children. And again, there are exceptions to this. Or as I say here, right, my surfer Spanish, which is terrible, I shouldn't be using an interpreter. I shouldn't be the interpreter. If you want to use, and I agree that you should, if you want to use crew members that are bilingual, excellent. Have a certification process, ideally have a pay differential so that you can reward that additional skill set. We need to think about capturing interpreter consent and patient consent for interpreter selection. The patient should have some agency on who the interpreter is, especially if you're using a family member or a bystander. It's not just anybody who is willing. And the interpreter needs to consent, and we need to find a way to capture all of that in our charting environment, right? And then we need to think about training our crews on use of interpreter and what you expect, and then having that show up in your QI or quality management practices so that you can keep a close eye on these very vulnerable populations.
So what does our house look like? Does our house look like a diverse group of individuals that also present very diverse ideas? Does our house look the same? And are we thinking the same? So you take a look at your own structure, and it doesn't matter if it's fire, EMS, your education department, look at it. And now if they all look the same, then now we have to inflex some change, something different, some new ideas. If they are diverse, then let's make sure we don't have this, well, because this person thinks this way, we should all think that way. Allow for that diversity of thought without folks getting ridiculed or being told that their ideal is dumb.
One additional item that I pointed to is the use of stereotypes and heavy cognitive load. So the use of cognitive support tools to help reduce that cognitive load can be very effective. And we know that it saves lives, and it is very likely to reduce treatment disparities. So as you think about your agency and as you think about your education practices, encourage the use of checklists, mandate them in some cases where there's heavy cognitive load, and then evaluate their effectiveness. They're not always correct, and they need to be evaluated and make sure that they are then consistently used, especially for vulnerable patients. There's one easy way for us to make a dent in racial treatment disparities. So now I'm going to talk just a little bit about the need to disaggregate your quality management practices by race, right? So here's a simple run chart, and this is real data. This is looking at traumatic injuries, 2015 and 2016, roughly 50,000 patients. And we're just looking at the rate of pain medication administration by month, right? And we can see that it varies by month, but it fluctuates right around the average line of there of about 18%. Which is not great, right? On average, we're terrible at providing pain medications. But the story is more complicated here if we start to separate out patients of different race. And here's what the real data looks like, right? And it's really noisy, right? So if we clean it up a little bit, and what we're seeing here are the different racial groups. And so this is just a symbolic representation to show that the averages by different groups are different. So if we separate system average into individual racial groups, we can see there's one group on the top here that happens to be white patients that's closer to 19.5%. Our average system performance is 18.3. But if we look at the reduction here, right, and the very bottom happens to be African Americans, they have a 42% reduction compared to white patients in this same sample, right? So we won't see that if our quality management practices only looks at system average. We need to disaggregate these by patient race as one example.
Have you heard these things? He done fell out. I got the sugars. Man, I got high blood. Oh, that's just so ghetto. This is ridiculous. I don't even know why I do this job. This patient don't do nothing but trying to get drugs. Is ignorant because this person's behavior is not up to our standard, or do they just not understand? Because what I've been told, ignorant is lack of understanding. Stupid is knowing what to do, but choosing not to. Does poor equal being uneducated? And do we really understand the patients that we are taking care of, understand their environments? So how do we get better understanding of these folks? We can actually invite different types of people to trainings, to classes. Maybe there's a homeless person that we run on all the time. If we actually sit down and talk to them and they come into an EMT class or come into a training, and we believe the overwhelming response from these individuals will be, I just want to be treated fairly. We can have these folks come in that are Black, that are older, that are women with children, for example, and really get a grasp and not allow the first time you run on them, your initial meeting, and you create this concept of who they are, because that sticks with you for a long time. So introduce yourselves to people who are not like you in a non-emergent environment. So the classroom's a good way to do that. Getting different types of victims. You know, when you practice with different people, you gain more comfortable behavior when you work with them on the street. And just don't say, well, we're going to do this for just 4 hours because we're going to fulfill some requirement. Make it part of the curriculum. Make it a systematic approach and make it just part of what you do. And you will see over a period of time, your students and your employees will provide better care because they have a better understanding of the people that they will be taking care of or currently taking care of.
Yeah, and just as a side note on that, in my department in our paramedic program, we have high fidelity sims that we run every week, and 100% of our standardized patients are patients of color. Because I know I've got a very white EMT, or I've got a very white, excuse me, paramedic student body in Oregon who may have never had any kind of intimate contact with patients of color. And so, as we've talked about, they may only see them on TV. And so it's really important in their education that we have racial minorities who are able to share their story, share their interactions, and have students interact with them in a clinical setting that's safe and a learning environment before they go out into the field. So one of the things my team and I did is we wrote an open source EMT lab manual. And so it is freely available. It covers a lot of these topics about uh, racial disparities, healthcare equity, a lot of the topics that aren't covered very well, in our opinion, in national textbooks. It's freely available. You can go grab it. And I just suggest if you do, please use it, let us know, and then make changes to it. It's meant to be a starting place, not an ending place, and I hope that you add to it so that we can continue to make it stronger.
So I have some experience in EMS. You know, it started back in 1995, EMT paramedic. Then I was a training officer for over 16 years at a large department in Missouri, and then moved to Indiana and was as a division chief of EMS. And so I'm saying all that to say that I've seen lots of variations of preceptors and folks that were responsible for ensuring that the next generation of EMTs and paramedics were equitable in their care and fair in their treatment. And that's not always the case. And so how do we do that? A lot of things that help level the playing field is by creating documents and checklists to make things more objective and not subjective. And when we're documenting these things, then I can look at this form, and if race and gender are documented on each one of these forms, then I know exactly how these patients are being treated. And I can differentiate between, well, this patient, because of their race, got treated differently than the other. The goal is that as preceptors, they are teaching their potential paramedics and EMTs that this is what we're looking for, and that those habits are good habits that begin, and that we don't start the bad habits because we subconsciously are doing what Dr. Kennel said earlier, not giving patients of color pain control because of misconceptions. So that's an important place to start. If you want to do anything and it's low hanging fruit, look at your preceptor training and document things that will help point out some of the obvious things that we talked about here today.
All right, so we've been through a lot of content in a short period of time. I want to commend Chief Randell here for finishing on time. We can both be a bit of talkers, so we want to leave some time for some questions. So just as a review, 11 things that you can do to improve your agency's treatment equity that we talked about. One is educating yourself. We talked about this is a very self-reflective process, which can be very difficult for some folks to get through, but a really important step in order to do this authentically and honestly and not just a checkbox item. Two, take a look at your LEP policies and improve upon them. They're likely not in a great place today, but they're worth being evaluated. Three, diversifying your employees at every level, but especially leadership. Especially leadership. I want to emphasize that. 4, talking about cognitive offloading, so building checklists for every cognitive heavily procedure. Many of us have these already, but I think they can be improved upon and used more widely. Educating frontline providers. This is a difficult one, right? That they may have a misunderstanding as they come to you as students or as workforce, that they believe race is a biological construct instead of a social one. So starting that education process to help them through that. And then making sure your quality management efforts are stratified by race, starting to appreciate that not everybody in your system receives the same quality of care. There's some that receive a substandard, and unless you disaggregate them, you will never see them.
So one thing that I think that's also important is that you have these partners in equity. And what I mean by that, Jamie and I think, an example of that partner in equity. We have two very different backgrounds, and we're bringing those backgrounds together to highlight things that are A, extremely important, but B, we're making ourselves better by starting with those very tough conversations. So if we can do it, we all can do it, right? Now, when it comes to educating folks, that's a bottom line, foundational floor exercise. And let's do that. Let's just talk about what's important, and it's the patient. And when we lose sight of that, then we lose ourselves. So it's important that we do that. So educate everybody on why it's important to collect all the information, especially the race, so that we're conscious of what we're doing. Track and report these things. Make sure that your documentation is clear, that it's objective, and that it makes sense. Not because you're trying to play getcha with your employees, but you want them to learn from it. It's a lot different outcome when you express it in those terms. Stereotypes are real, they happen, and we're not going to get rid of them. But we can be aware of them, and we can let people know what they are, even if they haven't been exposed to them, and give them solutions on how to handle them. And honestly, all you have to do is respect what other people believe and not jump into or exaggerate those stereotypes. Diversify your education and training curriculum and staff, like make it more inclusive, and make sure that the FTOs that you have are ready, and they're ready to deal with all types of patients, and that there are a champion of equity, not only for the patients, but also for the people that they're training, because they are training the next great EMT and paramedic that's going to potentially save Jamie or my life at some point, right? So we want people that are out there that have the compassion for all, regardless of what they look like or what they've done, that they are a patient that needs to be treated fairly.
So thank you all, and we're happy to take questions at this point. I want to first start out, David Green put a question in the chat, which I think is a very common challenge that I want to start with as you others are thinking about questions. And that is, he says he's often reluctant to assume someone's race, so he usually clicks unknown on the PCR. Absolutely. So there's a number of aspects to this. Well, one is agencies need to have a better policy around how to collect race, helping providers understand why it's important to collect race, and to give them some training on how to communicate that to the patient about why it's important that race is collected from the patient standpoint. Certainly, there's going to be cases where the patient's unable to communicate, and you have to make a guess on your perception of race. I think it is far more important to have what the provider's perception of the patient race is than the race of the patient, how the patient identifies. Ideally, we would have both. But our charting environment's not at a place where we can capture this. So I think it's okay to make assumptions, because really what you're charting is the perception of race, until we get to a better place in our charting environment where we can capture if the race that was documented in the chart was consulted by the patient. So thank you for the questions.
Yeah, and so to even further this, um, Dr. Kennel and I are more than happy to have these conversations offline and even help with your departments in moving towards that equity goal if you're not there already. So you have our email addresses. You can contact us, and we are more than happy to help with the process.
Great. And I'm not seeing any other questions here, but please let me know if they come up. And if nothing comes up shortly, I think, Rio, we can turn it back to you. And thank you all for taking the time. Really appreciate it.
Thank you.
All right. Thank you both so much for being here with us today and sharing your knowledge on such an incredibly important topic. We really, truly appreciate both of you. And as far as our attendees, thank you all for attending as well. I have put the link in the chat for the CE. And tomorrow I will send out a follow-up email, which will include the recording of today's webinar and contact information for our amazing presenters. So with that, I think we will go ahead and close out here. I don't see any more questions. So I believe that is everything. So thank you all, and I hope everybody has a fantastic day.
Thank you.
Thank you.
Thank you. Bye.